Hello everyone, let's continue from where we left off. See, here are here are some points that you don't have anywhere. Anywhere, like we are so specific about everything that these are the nerves they frequently ask. These are the nerves they frequently ask about, and just the way they ask in the exam, we have aligned all these things just using those words. Nerve passing through the belly of psoas major, nerve passing along the sides of psoas major, its genitofemoral nerve, its obturator nerve, and femoral nerve, lateral femoral cutaneous nerve. All these nerves are passing lateral to the psoas major, alongside of the psoas major muscle, lateral side. Okay, so they ask that a nerve passing lateral to the psoas major muscle, and it's causing pain at your lateral leg. Okay, so what happens that psoas major, we need to know the origin and insertion of psoas major. Only this one. Okay, so remember psoas major is originated from T12 body and L1 transverse process, and it's inserted into the lesser trochanter. Now, along the side, we have got lateral femoral cutaneous nerve that supplies the outer aspect of your thigh. And this nerve passes along the lateral border of psoas major, then goes under the inguinal ligament. In case of a psoas abscess, what happens? In case of a psoas abscess, what happens? It gets trapped. It gets trapped under this inguinal ligament. It gets trapped under the inguinal ligament, and it causes severe pain alongside your lateral thigh. This is called meralgia paresthetica. This is called meralgia paresthetica. And they ask you this thing, then they tell you some, what are the questions they ask? Number one, they tell you that a person is having pain along the lateral side of outer thigh or upper outer thigh. What will be the root value of the nerve that's supplying this area? What will be the root value of this nerve that's supplying this area? That's L2, L3, that is lateral femoral cutaneous nerve. Okay, and very, very important question. Almost like if you have three diets in a year, almost in two diets, they ask you this question in one way or another. Nerve passing under the inguinal ligament, remember all of these. Nerve entering the spermatic cord, remember genital branch of genitofemoral nerve, responsible for cremasteric reflex. So, what is an afferent limb? Afferent limb is ilioinguinal nerve that takes the sensation to the center, and then genital branch of genitofemoral nerve, that's the effector, exit limb, or efferent limb that takes it to effector organ, that is cremasteric muscle. That's it. And it enters via deep inguinal ring. Nerve passing through the inguinal canal, that is superficial inguinal ring. It exits via superficial inguinal ring, but it does not pass through deep inguinal ring. Very, very important. Remember these things: root of the penis, anteroscrotum, or labia majora. And it also supplies upper medial thigh. Nerve sitting over the spermatic cord, ilioinguinal nerve. Everything is a recall. Everything is a recall. That means a previous question that came in the exam. Nerve causing meralgia paresthetica. All of these things are 100% important. And after that, you get this summary. That's 100% important, integrated with standard references. Now, nerves to pelvic viscera. You do not need any of these things. Just remember sciatic nerve with its root value and its distribution. That's it. That's it. Bony pelvis, they don't ask, they ask difference between male and female pelvis. Okay, this is 100% important. They don't ask much, but these things, thicker, dense, narrow, short, wide, long, nothing to explain. Remember it as it's the first time you are studying. Remember it, all of it. Remember all of it. Short. Then they don't ask anything from this. You can give a reading if you want, otherwise not needed at all. Then greater sciatic foramen, lesser sciatic foramen, you need to know the boundaries. You need to know the boundaries. See, in greater sciatic foramen, we have superiorly anterior sacroiliac ligament that we don't have here, where we do have the picture. Okay. So we don't have the picture here because okay, I'll show you in the 3D at last. Okay, I'll show you at the 3D at last. So superiorly we have anterior sacroiliac ligament. Posterior medially we have sacrotuberous ligament, that is from sacrum and ischial tuberosity. That is sacrum and ischial tuberosity. Okay, sacrotuberous ligament. Then anterior laterally we have greater sciatic notch of the ilium. Anterior laterally, we have greater sciatic notch of the ilium, and inferiorly, we have sacrospinous ligament and ischial spine. Okay, sacrospinous ligament and ischial spine. So this will be our greater sciatic foramen and lesser sciatic foramen. Superiorly, sacrospinous ligament. This one. Anteriorly, we have ischial spine and lesser sciatic notch. That is this one. And posteriorly, we have sacrotuberous ligament. That is this one, sacrotuberous ligament. They don't ask much question. You just have to know the boundary for your own knowledge. There is no question from here. They don't ask questions from boundaries. They don't ask question from boundaries. All you have to know that if this is the greater sciatic notch, we have a muscle that is piriformis. And this piriformis divides it into two, that is suprapiriform foramen and infrapiriform foramen. And anything above suprapiriform foramen is superior gluteal artery, vein, and nerve. And inferiorly, we will have inferior gluteal artery, vein, and nerve. Okay. With that, we have sciatic nerve, pudendal nerve, posterior femoral cutaneous nerve, and for the serial. You need to know the serial. Let me show you the serial from lateral to medial. So if this is the piriformis, we will have first structure will be sciatic nerve. First structure will be sciatic nerve coming under piriformis or piriform muscle as a single trunk. As a single trunk. Below piriformis as a single trunk, mark my words. Just the words they use in the exam. Below piriformis as a single trunk. Then, then we have posterior femoral cutaneous nerve. And sometimes they ask that this is the lateral one, most lateral structure. And sometimes they ask a thin nerve you find medially. That is posterior femoral cutaneous nerve. Posterior femoral cutaneous nerve. Then we have nerve to obturator internus. Then we have inferior gluteal artery. We don't have vein here. Inferior gluteal artery, vein, and nerve to obturator internus, internal pudendal artery, and pudendal nerve. That is PIN. Pudendal nerve, internal pudendal artery, nerve to obturator internus. So why? Because these are the pin structure that's coming out from greater sciatic foramen, and you can see that it's entering the lesser sciatic foramen. So this is very important. So these are the contents of lesser sciatic foramen. Just remember obturator internus tendon with it. Now, this is 100% important information I just gave you, that structure passing from both greater and lesser sciatic foramen, that coming out from greater sciatic foramen, entering lesser sciatic foramen, internal pudendal nerve, internal pudendal artery, nerve to obturator internus. Nerve to obturator internus. Then we've got pudendal nerve from S234. Okay. And its course. Remember, it's above ischial spine. This is the spine, above ischial spine, and it will supply your perineum. It will supply your perineum. Okay. And in case of vaginal delivery, if you need an episiotomy, in case of vaginal delivery, so here is our vagina, and in case of vaginal delivery, if you need to give an episiotomy like this, which nerve you will be blocking. So you will be blocking pudendal nerve. Pudendal, because pudendal is supplying this area. All these areas supplied by pudendal nerve. Now, so for that, where do you block? So you find out ischial spine. You find out ischial spine and block here. You find out ischial spine and block here. You find out ischial spine and block here. So this is a very important question during a difficult vaginal delivery. You need to give episiotomy. Where do you block? You block at ischial spine. That's it. So this is 100% important. All the informations, I only tell you the information that will come in the exam, and you must not make a mistake with these things. Every single thing is covered. Every single thing is covered. Every single possible thing. Okay, and the things I don't mention, these are not important at all. Those will not come in your exam, and you will not get a question from those areas. Then pudendal nerve, everything about pudendal nerve is important. I have already told you what are the things that are important. S2 3 4, 100% important. So pudendal nerve comes from S2 3 4. It gives inferior rectal, perineal, then labia minora or posterior scrotum, then external urethral sphincter, external anal sphincter. So any incontinence after a difficult vaginal delivery or episiotomy, that is anal incontinence, or like after difficult vaginal delivery or episiotomy, you get urethral incontinence most commonly. So urethral incontinence, anal incontinence, these two, any incontinence is always pudendal nerve. Mark my words, remember this word. Always pudendal nerve, pudendal nerve, pudendal. Sometimes they will ask, a person is having anal incontinence. What's the nerve involved? Pudendal nerve. Second question, a person is having anal incontinence. What's the nerve root that are involved? Sacral 2, 3, 4. Okay. So these are the motor supply of this area. So any incontinence, it's always pudendal nerve. And remember, it's stress on incontinence. It causes stress incontinence. Now here I have written it in details, 100% important, 100% important. So you don't have to mark anything, just memorize everything mentioned here, every single thing. Very important. Episiotomy, anesthesia, pudendal nerve block, injection site, ischial spine, pudendal nerve, chief somatic nerve of the perineum, does not relieve labor pain from uterus. Okay, so remember these informations. These are just pictures to see. If you want, you can see, otherwise you can skip it. Internal iliac artery, I have shown you internal iliac artery. Now you have to know what where they supply. All of the arteries are important, 100%, very important. Everything that's written, remember it. Superior vesicle, obturator, artery to ductus deferens. Then inferior vesicle is absent in females and it's named vaginal. Then uterine artery, vaginal from uterine artery, internal pudendal, middle rectal, inferior gluteal. Posterior division, we get iliolumbar, lateral sacral, superior gluteal. Do not miss a single thing. Do not miss a single thing. Okay. Then from abdominal aorta, we get ovarian and testicular, abdominal ureter and testis. And epididymis, superior rectal, median sacral. These are not important. Okay. Remember it. Just to, why do skip? 100%. Remember these two too. Here we have added the pictures just the way I showed you in 3D. Then you need to know the lymph drainage of pelvic organs, all of it, all of it. And it's not like you go to some book and read those. No, read the ones that I wrote here, because that's how they give you choices in the exam hall. In the exam hall, if you have a choice of lymph node, you will have the choices presented here. You will have the choices presented here. Ureter and ureteric constrictions. Guys, ureteric constrictions, you just remember these three constrictions: pelvic ureteric junction, this area. Then the area where it crosses the common iliac vessels. Okay, CIA, common iliac artery. Then when it enters the bladder at the trigone. That's it. So these are the three constrictions. Why constrictions are important? Here you will find a stone if a stone is lodged. That's it. Bladder. Give a reading. Nothing important except these two lines. Artery, you already know that superior vesicle, inferior vesicle. Simple. Just these two lines, that the musculature is detrusor muscle and its epithelium is called transitional epithelium. Other than that, nothing is important. Then you go to urethra. Male urethra is 100% important, just the way I have shown you. Pre-prosthetic, not important. Prosthetic urethra is the widest, most dilatable prosthetic ducts open, ejaculatory duct open. So, sperm comes from testis and through ejaculatory duct, it comes to prosthetic part of the urethra. Prosthetic urethra. It comes to prosthetic urethra. Then membranous urethra, external urethra, sphincter, and this is the narrowest part. That means they will ask you that you are catheterizing a patient and you feel a resistance, but after some time the resistance is gone. So when you are feeling the resistance, you are at membranous urethra. Just like when you are doing lumbar puncture, you feel a resistance, it is ligamentum flavum. Simple. Then when you cross it, you are inside the dura. Inside, like you crossing in inside the vertebral canal, right? Then you have the dura, that is epidural space, right? Epidural space. Just like that, when you have crossed it, you just crossed membranous urethra. Membranous urethra, and you have entered prosthetic urethra, the widest and most dilated part. Spongy urethra wide at the bulb urethral glands open here. Okay, these are the important one. Artery not important, not important. No. Veins not important. Lymphatic drainage also not important, but this one is important 100%. Remember ejaculation, erection. Okay. Ejaculation, just remember hypogastric plexus, superior inferior is not important. Ejaculation, erection. Remember, erection is maintained by pelvic splanchnic nerve. Pelvic splanchnic nerve. Parasympathetic phenomenon. Parasympathetic phenomenon. Parasympathetic phenomenon will cause erection, and sympathetic phenomenon will cause ejaculation. Ejaculation. Like if you put it in analogy, if someone is sympathetic to you, they will cry, like water will come out, like they will cry with your sadness. So, with your sadness, a sympathetic person will cry. Water comes out. That's ejaculation. So sympathy is related to ejaculation, and parasympathy is related to erection. So every year they will ask you either about ejaculation or about erection. Always remember that. That's pelvic splanchnic nerve for erection, and for ejaculation, sympathetic hypogastric plexus. Superior inferior not important. Superior inferior not important. Forget superior inferior. Just remember hypogastric plexus. Then pudendal nerve. Pudendal nerve is 2, 3, 4 also, and it supplies membranous urethra, and of course the skin. It supplies mainly the membranous urethra, like the skin of the perineal area. Okay, the perineal area skin. Like your this is your anus and around this area. Anus and around this area. 2, 3, 4. Then epispadias and hypospadias is very important. This is very important. You need to know everything I have written it here. Let me summarize. What's the summary of this thing? The summary is you have to study what is an epispadias. When urethral opening is up, above. When urethral opening is down or ventral, this is hypo. If up or dorsal, this is AP. Okay, epispadias. And if they say urethral opening is anterior, that's normal. Don't confuse anterior with dorsal. Dorsal is dorsal, anterior is anterior. And that's the first thing you need to know. Then you need to know that associated with what? Associated with what? And what's the reason? Failure of fusion of urethral or urogenital fold. And epispardias, abnormal development of genital tubercle. And part of bladder extrophy, epispardias complex. Often associated with urinary incontinence, bladder neck defects. Hypospardias, epispardias. And what are the clinical features you get? Give a reading. Clinical correlations according to NICE, 100% important. 100% important. This is the NICE guideline for epispardias and hypospadias treatment. Remember it. This is surgical repair, and epispardias is pediatric urology referral. And we need multidisciplinary management because most of the time it's associated with your bladder neck defect. So we need to repair these things. Okay. And bladder extrophy epispardias complex. So that's why it's very uh, problematic. Female urethra not important at all. You can give a reading. Prostate. Remember the parts. Remember the parts. Others not important. Give a reading. Not important at all. Uterus. They don't ask anything. Anything. Just remember that cardinal ligament. Just remember one ligament, that is cardinal ligament. Okay. Cardinal ligament is the greatest support of uterus. And relations, 100% important. 100% important. This is very easy. That if this is our uterus, we know that we have anteriorly bladder, base of the bladder. Okay, anteriorly base of the bladder. Laterally, we have broad ligament on each side. Okay, and posteriorly, we have rectum, right? And in between uterus and rectum, we have recto uterine pouch, and in between bladder and uterus we get vesico uterine pouch. Simple and easy. Here we have it. Here we have it. So this is our uterus. Here we have vesico uterine pouch, and in front of cervix we have base of the bladder. In front of cervix we have base of the bladder at the lower part. Then we have rectouterine pouch. Then we have vagina also. And in case of vagina, we have got this base of the bladder 100%. Like all of the base of the bladder is anterior to the vagina. And posteriorly, we have rectum. That's it. So this is important. And artery is important. Veins not important. So this is the perineal area. They don't ask anything about perineal area. Just remember episiotomy. Just remember episiotomy. Episiotomy and perianal abscess. Perianal abscess or ischiorectal abscess. This is important. Only these are important. All of these things give a reading. They don't ask a single question ever in these things. No single question. Not even a single question. They ask from here. Contents, they don't ask anything. They don't ask anything. They never asked anything. So forget it. Don't waste your time. Remember what are the things I tell you. See, this is our ischiorectal fossa. And if we have, this place is open. This place is open. So if we have an abscess here, we call it ischiorectal abscess. Ischiorectal abscess. Okay. And this will be a horseshoe shaped abscess. Like this area is fully covered with pus and abscess cavity. It extends because this area is open. This area is a hollow area. Hollow area. So this abscess extends. Give a reading. They don't ask anything. Not important. You need to know the spaces in perineum. All the spaces you must know the names. You must know the name. Speciophagius, Douglas, fascia, Denonvillers, all of these things. And development, 100% important. They always ask you these questions. Nephrons, remember mesoderm. They give you this option, mesoderm. Then ureter pelvis collecting ducts. There is nothing to explain. All you have to know, where do they develop from? That's it. Epithelium, urogenital sinus. Trigone. Trigone epithelium is from endoderm, urogenital sinus. They will give you this portion, urogenital sinus. So do not skip the things I have written in bracket. Those they give in the exam. Trigone connective tissue and muscle is from mesoderm. So be very clear. Then male urogenital organs. They just ask, they don't ask much from here. So give a reading. Prostate, just remember urogenital sinus. Prostatic urethra, urogenital sinus. Membranous urethra, urogenital sinus. Spongy urethra, urogenital sinus. Just remember urogenital sinus. Female urogenital organs, they don't ask much, give a reading. Rectum, 100% important. And that's why rectum and anal canal, that's why I have given you all these things. All these things like urachus and allantois abnormality. Guys, see, we have it in pediatric surgery. Pediatric surgery. What did I tell you? That from umbilicus there is a line up to bladder. When we were in fetus, we when we were fetus, and urine used to come out through umbilicus with this line, and this line is called median umbilical ligament. N, median umbilical ligament. Okay. Now, before birth, when we were a fetus, it was functioning and it used to take urine from bladder, and with umbilicus it would come out. This median umbilical ligament is actually in the fetus as urachus. Urachus. And this is a remnant of allantois. Now, if urachus is not closed after birth, what will happen? You will get yellow fluid, yellow fluid coming out from umbilicus. So anytime a yellow fluid coming out from umbilicus, it's patent urachus. And they ask you a second question. Urachus is a remnant of allantois. That's it. Just remember these things. Just remember patent urachus. Others just give a reading, they don't ask. Median umbilical ligament, adult remnant of urachus, 100% important. Just the things I told you, I have written it down. Persistent cloaca, female child passing meconium through vagina. So remember these things, 100% important. Rectovaginal fistula, very simple. Cause, you just remember the cause. Trigone of urinary bladder, epithelium development, just remember the development. Okay, not important. Bladder cancer mostly transitional cell carcinoma because the name is transitional cell. That's it. Others, reading. So this is important. This is 100% important. And these developmental anomalies, they give you questions from here, like from 8, 8, 6 out of these frequently comes in the exam. All of the things I have told you, all of the things, these will come in your exam. So that's how our pelvis ends. Now let me show you pudendal nerve a little bit from our anatomy model. So this is our greater sciatic foramen. This is our greater sciatic foramen. This is our lesser sciatic foramen. Okay. So we will see the important structures that are coming out from here. Let's see from behind, from lateral to medial. You must know they ask you this question. We'll add the nerves. So first thing you have to remember that most lateral structure is this one, that is sciatic nerve, coming out under the piriformis as a single trunk. Okay. Then the second thing is posterior femoral cutaneous nerve. Very important. Very, very important is posterior femoral cutaneous nerve. Then we can see that this is our pudendal nerve. So pudendal nerve, where is it going? See, pudendal nerve is going. This is our ischium, and this is our ischial tuberosity. You can see, and the thing we hide it. So here we can see that this is our ischial spine. Behind ischial spine, pudendal nerve is crossing. See the ischial spine, it's crossing. So we block it here. Why? Let me show you why. Let me add the muscles. So we can see that this area is supplied by perineal nerves, which are branches of pudendal nerve. See, see, see. This is our pudendal nerve in blue, and perineal nerve coming out from here. Okay. So this is our pudendal nerve. See the ischial spine here, and this is supplying our perineal area. So now you know that why we give pudendal nerve block when we are doing episiotomy, right? Very simple and easy if you know where to look for and what to see. So you will never forget in your life. Now, so you can see that this is our puborectalis muscle. This is our puborectalis muscle. Let's remove that. This is our puborectalis. This is our puborectalis. And you can see that you have, if you insert your finger, if you insert your finger here, you can see that in posterior lateral area, you've got puborectalis muscle, and they ask you this question, puborectalis muscle. Okay. Then, then we were saying that this one, sciatic nerve, posterior femoral cutaneous nerve, then pudendal nerve. Okay, then pudendal nerve. Then we have internal pudendal artery. Okay, we have internal pudendal artery. And if we add more nerves, we can see that here we have, no, we have, here we have nerve to obturator internus. Okay, posterior femoral cutaneous nerve, posterior femoral cutaneous nerve. Then we have nerve to obturator internus, then internal pudendal artery, then pudendal nerve. And this one is inferior gluteal artery, and we have inferior gluteal artery vein and nerve here. Okay. And this is our superior gluteal nerve. This is our superior gluteal artery. These are supplying your gluteus minimus. Okay. Your gluteus minimus is supplied by superior gluteal nerve and superior gluteal artery. And inferior gluteal artery and inferior gluteal nerve is supplying your gluteus maximus. This is our gluteus maximus, and it's supplied by your, let me, okay, and it's supplied by this nerve. That is our inferior gluteal nerve. Inferior gluteal nerve, which is supplying gluteus maximus. Then superior gluteal nerve, gluteus medius and minimus. Okay. That's it. So, so that's how our perineum ends. Thank you guys, and let me know if you have any confusion about anything.